Good afternoon, everybody. A little disclaimer before we even start. We've had a number of power outages today. If that should occur, we will record it and you can listen to it at a later date. Hopefully going to get through this before our next storm. Today, we're going to talk about, and this is part 4 of a 5-part series, how COVID has impacted hospital charge capture. And first of all, we're going to start with a disclaimer statement. This is for educational purposes, and the copyright for CPT and revenue codes, as they may appear in the presentation, are in fact the representative by the American Hospital Association and American Medical Association. Today, we're going to cover areas most impacted by the pandemic, identify potential cost and charge implications, implications for preventative visits and primary care, and charge capture and cost management more than ever. And what you're going to find out today is that the pandemic has created different methods of access for healthcare, and they're not always in the hospital. We're going to be able to state the 2 areas impacted by the pandemic, be able to state why charge capture is still very important, why preventative services need to take your priority, and why cost management is more important. So when we look in the pre-pandemic as our baseline, as you'll recall from prior presentation, we are the highest cost alternative in per capita spending for healthcare. And you'll see we're way up there at $10,000, almost $11,000, where the rest of the countries are closer to the midline. Mortality rates have fallen throughout all the other countries. However, if you look, we were the highest cost alternative, and our comparable averages for mortality are not as good. We have higher death rates, higher preventable death rates, so we're paying more and getting less. If we look at our lifespan, we're only at 78.6 years. When you look at Japan, they're at 84, Switzerland at 83. So people that spend less, have more preventative care, live longer. And why is this happening? When we look at why we live less, there are socioeconomic factors that have created quite a number of these. One is coronary artery disease. That is a huge thing. And you'll see in the light green, we are above other countries. We do pretty good with cancer because we're one of the best in the world at screening for cancers. Diseases of the respiratory system, COPD, asthma, mental health and behavioral health, we're about even. But if you look at the external causes of mortality being those things like accidents and gunshots and things like that, that's much higher than other countries. And we see that the endocrine and nutritional and metabolic diseases are high. So we have a lot of inherent morbidity issues that other countries are not having. So when we look at the pandemic, what was the first thing I noticed was the countries that did really well, the people didn't die as often, they had quicker recoveries, they were able to battle the pandemic, were those countries like Norway and Netherlands and what have you. And they're on a well model of care, meaning that their entire life is based on health-seeking behaviors. Where in the United States, our healthcare delivery model is based on a reimbursement system, and that reimbursement system encourages more procedures and services when we're sick. So there's been a statistic out there for a long time that 80% of Medicare's dollars are spent in the last 20 days of life. So we do services, but only when we're sick. In other countries, the debilitating factors are prevented by encouraging lifelong preventative services. So not only did we spend more, we had more comorbidities. So we were really behind the curve in being able to battle the pandemic. The other countries' reimbursement is driven by quality outcomes and community health versus the services or volume of services rendered. So to be fair, we started off behind the curve. if we look at the Commonwealth Fund, you'll see that diabetes, hypertension, chronic lung disease, and heart disease, we are considerably higher than anybody else in this, in the civilized world, and these are due to our life behaviors. If we also notice, there are many other countries in which the age of 65 or older, or 80 or older than us. So we're seeing these in a younger population. Other impacting factors on the pandemic were loss of employment and healthcare provided by the workplace. Suddenly we had a lot more uninsured, and underinsured were always a problem. So the socioeconomic delivery of the pandemic actually affected their people's ability to get healthcare. Severity and comorbid diseases, obesity and diabetes are creating poor outcomes with COVID. And for many areas of the country, these are actually related to some socioeconomic, not being able to get good food, or just the industry, selling us junk food. So isolation is creating significant mental health concerns, and we're seeing now, there was an article released yesterday, American Society of Pediatrics, that the isolation in children has created a significant increase in mental health concerns. We're seeing our suicide rates go up, and we really don't have any access to mental health as for most people in the country. And then the inability to access a healthcare provider outside the emergency department during the pandemic. Primary care was overwhelmed with just managing the day-to-day. There was also a shift to urgent care and convenience medicine, CVS and Walgreens, because they were offering drive-through testing and they can treat minor illnesses. So now we're seeing people that the hospital may have lost for some minor services in the future, because people are finding out that convenience medicine really is the way to go. Stay-at-home orders like Zoom increase the adoption of telemedicine. We see that telemedicine is really being adopted. Its cost to provide telemedicine in a home setting is a cost to provide in a home setting is $203, in office like $180, but in telemedicine it's $52. So we're seeing people start to do telemedicine, and that's evidenced by commercials like GoodRx, that you can just go on an app and get telemedicine. You can pay cash, and it's significant less than you would get for your copay and deductible if you go have insurance at a hospital, or if you don't have insurance, it definitely becomes unaffordable. So again, these hospitals kind of zoned in on the sickest patients. Elective but non-emergent procedures were delayed, and that's for $161 billion for 4 months, the first quarter of 2020. So that's a significant amount. The demand for specialty equipment and disrupted supply chains increased the cost due to low supply. So N95 masks and gloves may have, for example, and this is a wild example, $1 a piece, but with the supply chain disruption and the ability to get them, the supply and demand of macroeconomics sends them sky high. Staffing became truly impacted. And now, even though we have nurses, we have a shortage of front-end workers because they became burned out, or the financial impact of continuing their job where they, were going to expose their families, and they were able to find other jobs. And finally, there are fewer physicians in the US, and of those physicians, a lot more of them are specialty than in other countries. And so we started off behind the curve with the ability to provide physician visits. So we're short on primary care. American Hospital Association, and I've given you the reference, in May of 2020, issued a report that's really pretty straightforward. And they basically said the total of 4 months of financial impact is $202 billion in losses for America's hospitals, or an average of $50.7 billion per month. And this is going to affect all hospitals, and the rural hospitals were least capable of being able to impact this. So of course, we're starting to see the impact of financial distress on the rural communities. Hospital costs, including childcare, because a lot of people had to come in so much, they brought childcare, they were single parents. Enhanced PPE. Nurses and physicians were buying their own PPE because the hospitals didn't have it or didn't have a budget for it. Transportation and housing cost. A lot of the workers were brought in from other states, and there's transportation and housing. So this whole pandemic affected the hospitals in ways we've never seen before. The AHA further went down into 3 categories of claims, and they said emergency department related claims, non-emergency related claims, and not medical and surgical. So in all 3 categories, there's cancellation of 67% of ED related service, and those are tangential services. Cancellation of all non-ED related services. In level 2, they saw 50% of non-ED medical and cancellation of all surgical. And in level 3, they canceled 50% of all non-related. So basically all the services being offered by a hospital, including some of the ED services, were reduced due to the demand. So there's another report. The same report was issued by Kaufman Hall, and I really recommend you read the whole report. It's absolutely very telling. Pre-pandemic, 25% of all hospitals had negative margins, negative operating margins. Post-pandemic, with the best view possible, 39.2% will have a negative margin, and a pessimistic view, meaning the worst case scenario, approximately 50% or 49.1% will have a negative margin. And rural health, as we expected, is going to be severely impacted, and many of those will not be able to bounce back. And the recovery is based on multiple items outlined in the report. If we look at the revenues, this is very telling compared to 2019. If I look at the 4 quarters of 2019, I'm at 4.8 to 6.5 as far as percent. When I hit 2020 or the March beginning of the pandemic, I'm at 0.4, but in Q2, I'm minus 8.9. I'm just starting to come back. And what happens? We have our next version of the pandemic, the Delta variant. So as we're noticing, health-wise, we started off behind the curve. Cost-wise, we started off behind the curve. Provider-wise, being primary care, we started off behind the curve. So there's a number of reasons why America is struggling to keep their hospitals alive and functional. We're reevaluating where we're at, and we have seen that the temporary hospitals or tent hospitals that were set off are now down and closed. The Hope boat is closed, so we're not seeing that. But we were starting to see a swing towards normal ICU admissions, and the Delta variant hit, and we're starting to see an uptick, but not to the degree of the original one. Vaccinations are well underway, but we have free will in this country to decide whether we want it or not. And unfortunately, many in the medical industry, or fortunately, depending on who's looking at it, they have decided they're not confident in the vaccine, or they are confident in the vaccine. So this has become somewhat politicized, and it's hurting people from making a choice because they're basing it on the news. We're seeing the initiation of non-scheduled procedures and surgery. We're seeing scheduled procedures again, and reevaluating the charge capture process and ensuring that prior policy procedures are still current and require modification. Now, one of the reasons we want to really focus on charge capture is many of our institutions have moved the middle revenue cycle people off-site, where you were all working together and could share IDs, and you were all in the same room or in cubes that were close by. You may now be working from home, making it harder. So the ability for the silo concept is back, and it can impact our charge capture processes when we need it the most. Post-COVID evaluation, we see what are the revenue implications. So what's the implication with collection? What's my point of service collection if in fact I have patients that need services, but they're no longer employed and they don't have the money? Bad debt is expected to go up. payer contracts will remain the same. They're not changing other than the provision under the emergency use authorization, the EUA, to get the COVID vaccine and some of the COVID-related services. Cost implications are much more severe than they've ever been. We see significant supply chain disruptions, huge disruptions in pharmaceuticals, and the number one spend that was expected for 2022 and 2021 is in enhanced cybersecurity due to the number of ransomware attacks. The cybersecurity is one of those costs that we have to do either way. What are the quality implications? Well, demand impacts the quality. So if we have less providers, more demand, then we're going to go as fast as we can to make sure everybody gets it. But the quality may not be as high as it was before. And we're going to need new quality metrics post-pandemic because there are new factors. So when I look at these elements, courtesy of Health Catalyst, we see there are three major categories: revenue, cost, and quality. And if I'm in the revenue section just alone with charge capture, cash Excel, and collection rate, we're going to have issues there. The other thing we're going to see is a referral leakage, which was one of our drivers at Health Catalyst, is to get referrals to stay within the system. We're going to see referral leakage over to the Walmarts and the Walgreens and the CVS and concierge medicine. In terms of labor, our supply chain has a significant, where we would drive the supply cost down, the surgical costs and general supply, we would drive them down because of the exterior supply chain worldwide. These are now escalating. So our costs and vendor costs are going up. And so these are things that we try to control by getting our labor right, our staffing contracts, and getting this orange section really focused on during a normal operating period to keep your ROI. Now we have things that are out of our control under the supply chain. And clinical operations, population health becomes a very big factor, and care management. So as you can see, we have a lot of different levers that we can pull. The problem is the pandemic keeps evolving in different ways, and the levers we pull may not be the lever we need tomorrow. When I'm looking at revenue impact, I've already talked about that first quarter of 2020 where we had massive losses. There's going to be an increased primary care to accommodate all those services delayed during pandemic. And we know for a fact, and the CDC, World Health has said that people that had scheduled visits and scheduled regular follow-ups for their physicians, they didn't go because of COVID. So now we're behind the current. Those screening tests like colorectal screening and mammograms and things like that, they've been delayed. So there might be an uptick in newfound diseases. Institute elective procedures to create revenue. We're going to need to get those electives back, especially hips and joints. But what I'm seeing is the insurance companies are also responding with more joint bundles. So that's becoming an issue. Minimize cost to provide the care and cost to collect, and maximize your quality, and continue to focus on keeping the patient within the system. So we need to kind of move them from the sick model to the well model, which culturally has been an issue in the United States in the provision of healthcare and in the way that Americans think about obtaining healthcare. So when we look at this, our key success measures are get the electives back and really work on the cost and maximize the quality. Here's a revenue cycle, and it hasn't changed in any way, shape, or form, but now we're going to really start to focus on the patient access, because a lot of people have lost their insurance. So the eligibility, if the patient access just recalls the last visit, and that last visit had data from an insurer and now they don't have insurance, that's going to change. So we're going to see a lot of errors with eligibility and authorization unless we're very articulate with our process. And then our charges entered by staff, we've used a tremendous amount of ancillary staff and outside staff to provide care, temporary floaters, locum tenens, all sorts of people that may not know what our charge capture process is and may not be as articulate with it. So we need to focus on the light blue and the purple as we move forward to get our money back. General revenue concerns or processes that work to increase patient involvement has to take a primary focus. One of the things we're noting coming out of the pandemic is the patients, they're not as involved with their providers they were. They've been forced to seek and use other methods. So some of those relationships have staled. I mean, I tried to make a doctor's appointment for my dad, and they're giving me an appointment in February of 2022. This is unfortunately August of 2021, and we cannot wait 5 months. So you find alternative things, and we turn to telehealth. So we're going to see telehealth becomes the new thing. We're going to have to really focus on aggressive programs that address cancellation and no-show rates. No-show rates are going to be very high because some of these appointments were made during the pandemic and the patient has sought care elsewhere. So we really need to have those follow-ups. Are you coming tomorrow? I'm starting to see a lot more text messages, confirm your appointment, and then the day before, confirm your appointment, and then a welcome to your appointment that morning. So we're starting to use technology more and more. Multiple step internal controls to alleviate demographic eligibility and auth errors and inaccuracies. This is going to be paramount for the authorization nursing staff, as well as the patient access staff and surgery scheduling. You will need control points at the point of registration. You will need a control point at surgical scheduling to make sure that eligibility and auth is there. And then the morning of surgery, when they come into the pre-op area, confirming the authorization and eligibility again. So you're going to need a 3-step process, or you're going to end up chasing as a denial. Revenue cycle must audit through either software or manual approaches to increase the clean claims. We're starting to see clean claims rate go up, meaning there's some failures, and avoid charge leakage to prevent denials. So cost management O2, their pandemic revenue cycle, 2 significant components. One's going to be charge capture and the other one's going to be cost. And you're going to have to manage both of those with extreme efficiency. Charge capture, start with the CDM. Is it correct? Do you have all your right COVID codes in there? Do you have all your right ability to check for the diagnosis codes on the bill so that you don't get denied? Review preference cards in the OR and cath lab. They have been made pre-pandemic, and maybe you're not using those supplies anymore, or the supplies aren't available. Make sure they're up to date, because we know OR and cath lab are going to be 2 areas where supply chain is going to be the most disrupted. Utilize a process with or without software to review your charges and ensure correct charge and CPT and units of service. I'm seeing quite a number of unit of service issues on pharmacy items on final bills. So once again, we need to focus on the basics. You know, what is the drug? What is the bill, the dispensing unit? What is the billing unit? Look for the package. And we're also seeing an increase in package services. So that's a problem. The pharmaceutical supply chain also has been extremely disrupted. When we look at the second piece of the puzzle, or the mirror image, we're trying to control our costs. Enhance focus on utilization and practice patterns. So maybe we can't give every doc what they want for their preference in devices. Supplies depending on data through cost accounting and activity-based accounting. And last time we went through the activity-based accounting, but basically if we're taking our charges and reducing them to cost through a cost to charge ratio, every patient has the same cost attributed to their care. However, if you do activity-based costing, you're going to really start to get that granular look about what's happening in your institution where you might be able to control costs better. So this is really making a new focus on cost and cost accounting system, something that hospitals really have not done well for years. And we're going to be looking for more ROI in the cost management than the reimbursement. So when I'm starting to look at trends for 2022, they're looking what they call the deflators. Price Waterhouse has an article out there, Deloitte, they're calling them deflators, things that are going to deflate the cost to provide. As I go back to that one too, also an inflator of your cost is not only cybersecurity, but most hospitals are trying to prepare for that next pandemic. And that next pandemic could be as simple as another variant of COVID or a whole new disease. I mean, I noticed that Ebola is on the rise again. So what they're preparing for that next pandemic, and there's a lot of costs associated with that. So if I look at charge capture, hospitals, again, are going to start to focus on it, reminding ourselves that we may be remote, which makes the manual method more difficult and kind of pushes you into a software version. Software will allow for 100% consumption of daily charges with rules, targets, artificial intelligence to cue your concern. So on your screen, you see one of the rules that VitalWare has, where these are all individual patients where there is a missing blood product, but there was a blood transfusion. So these help you capture those charges before they go out the door. When I'm looking at a charge capture audit, I started to see during the pandemic that the 5 key phases of the charge capture audit kind of fell apart because A, you're not in the same place to do it. B, the protocols you set up were for normal everyday operations, not pandemic crisis after crisis. So we need to go back and when we're auditing, what is going to be the standard? So we want to consume 100% of daily charges. We're going to measure it against the current standard, which is coding and CCIs and MUEs and P2P edits. Compare the results to a standard practice. So we set the standard. What does the result show us when we reviewed those 100% of claim, and then change the practice? Now, this dark blue section is one area that hospitals typically do very poorly at. You'll fix something and I'll go back 6 months later and it's like, why is this happening again? You leave a smoldering event and then it catches fire again and you're right back to the way that used to be. People in times of crisis go back to a level of comfort. And so therefore, some of the changes you make, you may have to revisit to make sure they occurred. So let's talk about the hospital and the primary concerns. First of all, we're going to routine preventative service and identify those who are behind missed altogether. This is where population health really comes in. You're this age, what services should you have? And let's get them scheduled. So we want to take a specific and distinct factor, laser focus. Let's get preventative services back up and going again. For patients with active diseases, not only preventative services, but care models and frequency are essential. So if we want to keep our costs down and our quality up, that means we're going to have to follow them more and more. So you see things like the more increased telemedicine at the Veterans Hospital, where they're checking on people that have hypertensive crises or diabetes or renal failure, especially renal failure, where they're getting daily weights. And anybody starts to gain weight, one of their practitioners reaches out to them. So population health and preventative services now become a mainstream focus. Many patients are unemployed. So they're not going to go to the doctor, but we still need to focus on the socioeconomic and potential for coverage. So you're going to start to see an increase in well care clinics. That may be through a concierge. It may be through like convenient medicine, like Walgreens and CVS, or it might be through community-based wellness centers where people who are unemployed or don't have the funds, they may go to a community center. We need us to be a source of education about the vaccine, who is headed. And when I say a source of education, I mean factual. What is it? How many people are getting sick from it? What are the complications from it? So a reader at a 5th grade level or 3rd grade level can understand what you're trying to say. Unfortunately, if anyone was to listen to the news, you would have 2 polar opposite ideas about what you can do and can't do. Many commercial payers are now saying instead of on-site visits, we want you to conduct your health care for like diabetes and for your blood clotting factors, INR, and all the things you used to do. We want the pharmacist and we want mid-level and we want the physician to be saying, let's use our telemedicine service and you can run it through our insurance company. Preventative visits delayed during the pandemics are another opportunity to re-engage with patients. So remember, I told you some of those provider-patient relationships were disrupted because patients got dissatisfied, they couldn't get in. This is a great time to build those relationships and not lose that source of revenue. Population health, where we were dabbling in it before, we need to be all in. And that's what's considered an inflator by many of these accounting firms. An inflator meaning we're going to have to spend a lot more costs in order to be able to undertake population health. Comorbidity, we have to start earlier. Obesity, diabetes, hypertension, respiratory diseases, they have to be followed very closely, and we have to manage them early on, not just when the patient gets sick. So if you have a 10-year-old that's 300 pounds or has diabetes, we have to start that early, and getting away from, just junk food. Fewer primary care providers. This is a huge problem because American medicine was so focused on reimbursement and specialties because they got the highest reimbursement that, everyone, if you went to med school and you wanted to pay off your loans, let's go to cardiology or cardiothoracic or neurosurgery or anesthesia where I get the big bucks. But now we don't have primary care, and the primary cares are getting so burned out through documentation requirements and volume that they're leaving very quickly in the system. So that burnout's a problem. So when I look at preventative services, your hospital should have some sort of mechanism for checking for all of these preventative services, no matter if you're 5 or you're 105. These are the Medicare FAQs on preventative services. Many of them will not occur. But if you go to the Medicare website that I've given there, you just click on one of these and it'll talk about it. So flu shot administration, come September of every year, everybody who's in a risk group should be notified either by email, text, or call about your upcoming flu shot. Your preventative exams, your mammographies at certain time. And so we need to really be that source of constant reminder. And in many cases, we're going to end up incurring the transportation costs to get the people to do this. Facility-based weight loss. This was a huge revenue producer for hospitals, bariatric centers of excellence. During this pandemic, the nutritional consults, diabetes education, it was all impacted. And many patients moved away from facility weight loss programs that were governed by certified nutritionists and physicians and sports exercise physiologists and what have you, and then went to self-management. So you've seen an increase in Weight Watchers. You've seen an increase in delivered meals. I mean, every night, if you watch TV, I get 5 or 6 people on the TV that are offering to bring me fresh pre-cooked meals of nutritional value. Supplements have grown. So we're moving away from those facility-based weight loss into more of an outsourced weight loss. Medical weight loss programs were $7.78 billion in 2020. They are expected to decline 16.3 or 7.78 billion. And due to the 8 to 10 week closures of programs in the hospitals, clinics, physicians, hospitals were scrambling to deal with regular patients, not weight loss. So weight loss surgeries are falling by 17%, and they're not expected to have a quick pickup because of the fact that we still are getting preventative and primary care. So this was a very significant source of revenue to a number of hospitals. When I look at elective procedures, the 2019 study on revenue impact for elective showed that cancellation of all elective procedures would result in about 16.3 to 17.7 billion per month in revenue and 4 to 5.4 billion per month in net income to U.S. hospitals. I don't know that hospitals are prepared to take that type of hit. The likely economic impact of fewer elective surgeries on U.S. hospitals are part of this problem. When we look at the bread and butter electives, they're significant contributor to the bottom line prior to COVID. We wanted those electives. That's why surgeons fight for their OR time. As the pandemic changed, like more normal pre-pandemic appearance, we're starting to see electives come back, but they're backlogged. We're needing to do all that pre-testing. We're needing to get medical necessity again. We're needing to get the authorizations again. It's going to be very crucial that we pick up where we left off in the most expedient and efficient manner, but accurate. We have to be accurate, because if we lose an elective, that's not money we can afford to write off. So we need to make sure that all those charge capture things are there. We want to say on the front end, as I've said repeatedly, about 40% of all denials are resulting from some sort of demographic or eligibility or authorization issue. And we noted this was an issue. Post-pandemic, the performance of procedure without those authorizations is going to lead to a denial and increased cost to get it, and lost reimbursement. It also impacts your cash flow. I mean, it can take years to get to an administrative law judge, the amount you're going to have to spend on attorneys. So we want to make sure that we get that right. The other thing that the population and the healthcare providers is very concerned about is that we, during the COVID thing, we were pretty much registering people and saying, is this where you live? Show me your card. But right now, we're starting to see a lot of duplicate name, duplicate accounts, and things like that. They select the wrong account, and that starts the EMR process. The problem is, if somebody is allergic to penicillin and you get the wrong person, you're going to maybe give them penicillin and create a medical error. So we're starting to see medical errors go up as a result of pandemic too. So these are costs that have to be controlled through slowing down, taking a breath, and doing it right. Joint replacements are really starting to come back, but what we've seen post-pandemic is more commercials are instituting a package process somewhat similar to CMS. So we're starting to see those joint replacements, see more integration between facilities, physicians, and post-discharge. What does this mean? This means you're going to have data on your costs. You're going to have telemetric follow-up to make sure that their people are doing what they need. You're going to need home PT, and you want to keep them out of a building. You want to keep them home. So this is going to mean you focus on cost management, labor, and device costs, and enhance patient interaction to prevent readmission and complication. So there's a company called Twistle, and they do nothing but work on the enhanced patient interaction, which not only helps with your patient satisfaction, but they found huge amounts of ROI for enhanced involvement in early detection of concerns and effective management. So this is what we're going to start to see is we really, if they're going to go down the bundles and we're start to go down quality, we need to have more patient interactions in a cost-effective way. So this is one of the post-pandemics, and as telemedicine comes back and what have you, we're going to start to see new touch points for the patient that we had not previously really used. Guidehouse said, as far as the supply chain, unnecessary U.S. hospital spending reached $25.7 billion a year. And that said, from 2017, it jumped from 22.6%. So the supply chain costs have gone up about a quarter. To 12.1 million. This is an equivalent jump of the average salaries, 168 registered nurses, 51 primary care physicians, or a cost of 3,100 knee implants. So supply chain now becomes a cost management resourcing issue, and it's not just the old inventory management. You have to have a lot of data on your supply chain. And one of the things we saw with the supply chain is they put something in, and I'm going to use this name just an example, Lawson, or some supply cabinet. And when I get the thing on the bill, it's like, okay, I have a non-vascular balloon that's used in endoscopy, just was used on a coronary arteriography and angioplasty. Well, you know that's not true. So we're starting to see HCPCS codes that were assigned by people who were not familiar with the coding system in the supply area. We're now starting to see where that's becoming a problem. So we need to go back and look at all our catheters and our devices. I have a lot of claims that we've looked at here at VitalWare. We have found single chamber pacemakers being charged instead of dual chambers or AICDs. So we see it even in the high cost devices. So you want to focus on vascular versus non-vascular catheter, pacemakers, and implants. You want to go to the cath lab and look at all their supplies, make sure they're coded right. And if they have preference cards for the physician, make sure the correct materials management number for charging is on it. Same for implants. It's essential that the device or implant on the claim matches the implant log. And from my background as an auditor, whenever I wanted to deny something, I would go to the implant log. And if that device on the claim was not the device in the implant log, I would automatically deny it on plausibility. So this causes you a cost issue, and you start to look at these things because remember, the payers are going to pay at a percent, usually their carve-outs at a percent of charge. And their first goal is to say, hey, you didn't use that, I'm taking it off the bill. So we want to make sure that these devices are done rightly. Here's an example. This is Vital Knowledge, where you can look up a model number and it will show you the device name, manufacturer, and the actual HCPCS code used. If you look at these, they're all Bellows DRs or DRTs. But what the difference is the first one is a C1785. It's a dual chamber rate responsive. The next one is a dual chamber cardioverter. So it's C1721. So if the supply chain is just looking at Biotronic, and not really getting into the different types, which they may not know the different types, therefore you're going to get the wrong code on the bill. The other thing I look at is the Medicare standard analytic file called the limited data set. It helps ensure that procedures using a specific device are identified. So by reviewing that, the department can see potential procedures. If the procedure is not on the SAF, for that device, you'd likely have some sort of coding issue. So here's an example with C1785. And if you go below 25%, it's likely an error. So you see all these different things that you would see with C1785. You know, and if I have a whole different set of procedures, then I'm likely to have not coded it right. So that's another way to look at, is my procedure and my supply matching? Now we're going to get into an area that has been a focus for hospitals for a decade now, pharmacy. And pharmacy was really impacted with COVID and the back orders. They have shortages. The hospitals used to be on a limited number of days supply because they could get it in pretty quickly. As a result, they've had to increase their days of inventory to make sure it's on hand because it takes so long to get it, or it's back ordered or whatever. Well, every time you buy something for your inventory, to increase your cost. So we're seeing pharmacy department costs go up because they have to increase the number of days to make sure it's on hand. The growth of ICU beds and expensive drugs just skyrocketed. Pharmacists have resorted to telehealth for patient interactions like Coumadin counseling. Enhanced use of outsourced vendors to manage supply chain, because this became so overwhelming to pharmacy supply chain internally, unless you have a huge supply chain during the pandemic, that a lot of people had to outsource to vendors that are capable of getting them the supplies they need. That's an increased cost. Operational changes around the return of medicine for credit. So say the daily bin went up to the floor and there were 10 meds and you only use 3 of them, you can't bring them back because they were in a COVID area. So we're seeing these are being straight costs to the facility because they have to be taken off the patient bill. So these are non-returnable costs. So if you look at the pharmacy area, it's getting hit and hit hard. with increased inventory, increased inability to return things. So if I look at this, the ASHP report for operational changes said that 77% will continue to use premix, but 73.9% expanded telehealth for pharmacist visits. So 3/4 are now expanding it. We see 67% have expanded the use of outsourced vendor for sterile products, remote verification. We see that permanent increase in days of supply a little bit, and staffing reductions. So we see a lot of impacts. The other thing we're seeing is enhanced medical necessity guidelines on pharmaceuticals. So where I may not have needed an off before, I need an off now. We're starting to see the compassionate use and payer requirements for compassionate use. So if you have a drug that's being used in compassionate use, there's quite a to-do to be able to get that for reimbursement. Payers are starting to require what used to be optional, which are brown bag, white bag, or clear bag. And I'll speak to that in a minute, but oncologists have raised the alert that they don't want any three of these because they include safety and wastage issues. And so therefore the providers are really quite against what the payers are demanding. CMS and payer guidelines for specific COVID medications and treatments have to be followed. So that's going to be something with your billing office and charge capture. So as you see, this pandemic has basically set the pharmacy department on fire to be able to deal with these things. Now let's talk about what payers want. Clear bag is a facility internal retail pharmacy, okay? So it's your pharmacy, it's a retail pharmacy, it has its own retail license, it receives an order from your facility, creates a medication, and delivers it over to the administration area, thereby decreasing the sterility and error concerns. But most people don't have a retail pharmacy that can do this. White bag is an external retail pharmacy receives the order, creates the medication, and their courier takes it over there. But the problem is the area where it's being delivered, say oncology center, must hold the medication till the patient arrives. Well, it has to be held at a special temperature, and maybe it's light sensitive and all sorts of things. So this can create wastage due to inadvertent events. Brown bagging is where this is the least preferred, where a patient has a prescription, takes it to their pharmacy, gets their insurance for that item, then carries it over to the hospital or the treatment area at the time of service. So this creates immense sterility concerns and safety concerns. What if they left it on the front seat of the car while they went in shopping for 2 hours and it's 98 degrees out? So this brown bag presents a lot of patient safety risks. In most hospitals, if they do brown bag, there's just really a strong protocol. But now seeing that payers are starting to move towards this, I think hospitals need to be prepared to manage this operational concern. Pharmacy charge capture. If there's not a business associate assigned to just charge capture in the pharmacy, it might be a time to think of one. With your increased costs and your cap charges and your authorizations and all of that, first of all, they need to make sure the CDM matches the inventory. Mapping between the ordering systems to the pharmacy, to the dispensing cabinet, to the CDM, and to the billing module. So you may order an aspirin and charge on the bill for lidocaine if the mapping is wrong. Multipliers on the bills we're looking at lately, multipliers have become a big issue again. So putting a multiplier on one when you're entitled to payment of 20 units and you use 15 units, that means that you're going to miss 14 opportunities for reimbursement. So you need to test the claims for all your high-cost drugs by creating a fake patient and checking your inventory. Software is made to be implemented to look for charge capture and volumes of medication. So again, we're back to you may need charge capture software. And here's an example of a rule for abatacept, okay, where if JL129 appears on the bill, and it's less than 50 units, and you're greater than 17 years of age, then stop this claim because you should have had 50 units or more. And if you only have one on it, it's going to catch that and stop it before you lose your charges. Charge capture and costing pharmaceuticals charge in such volume every day, you need software to consume 100% of the charges. The rules and ability to create specialty rules are based on practice patterns. So the ability to change your software becomes a big issue and deterrent if you can't change it. Activity-based costing is now key. It's front, it's center. It's no longer an option. You need to know what your costs are, especially if it's activity-based costing that involves supply chain. Maybe there's a specific supply you're using for the GI lab that's costing more than everything else, and it's costing more by the time you're through the supply chain than you actually get for the procedure. So you want to do your activity-based costing, which brings it down to the individual patient and supplies used and pharmacy used. So as we close out, pre-pandemic factors and per capita set us off on the bad side of the curve to begin with. We spent more, we had higher cost alternatives like MRI, CT scans, which are done at far more volume, less physicians, and so we're spending more for less. We have significant comorbidities that represent a cost to manage, such as obesity, diabetes, and mental health. COVID has increased the suicide rates, and these are preventable deaths. Fewer physicians, and the isolation has also increased the suicide rates. And when also in the suicide rates, I want to talk about the fact of it wasn't suicide, but inadvertent overdoses. We saw a pandemic where there were heroin overdoses left, right, and center, and that's still coming true. If you read the news, you see that in public parks and in storage areas and what have you, there's a new brand of drug use out there because people don't have jobs, they don't have anything to do, they become addicted or they are addicted, they may be homeless, and all those socioeconomic factors lead into some preventable deaths from mental health, suicide rates, but also within people who can afford everything, we're starting to see with isolation, whatever, a higher suicide rate, or somebody lost a loved one to COVID and they don't want to hang out anymore. So this has really created a mental health emergency in America and every other country. We have fewer physicians, fewer patient visits per year, and utilization of more expensive testing. So if you go to Norway, there's almost 3 times the number of patient visits or interactions with a provider than there are in the US, and they have almost zero use of high-cost alternatives unless it's really a trauma or use. They don't CAT scan every person that says they have a headache. During the pandemic, the routine preventative care has fallen by the wayside, and due to isolation, we need to get it back. So this gives you another chance to re-engage your patient. We're going to have to really focus on pharmacy and supply chain for those costs because they are escalating, and they're expected to escalate through the next 5 years because of the changes in supply chain backlog and because of the countries, that a lot of it's made in one country and that country doesn't deal well with other countries. And so we're starting to see that shift. Hospitals that put elective procedures on hold are now coming back. Facilities continue to lose revenue. And again, a negative 49% profit margin isn't going to allow you to continue as a facility. So we're going to see the impact on the rural and the smaller hospitals. Facilities see reduction in elective surgeries due to payer requested lower charge settings. So this year we saw the return of the inpatient only procedure list in the proposed rule for OPPS. That's because facilities have been driving many procedures to lower cost alternative settings with the same quality output as the ASC, but now physicians are pushing back saying this, this isn't safe to do at an outside location. We're going to need aggressive management of the revenues, so front end, eligibility, auth, CDM, mapping, all of this has to be reevaluated. We may have had processes to spot check, but as we're getting started up again, take a big procedure on the surgery schedule and look to make sure all the mapping's done. Charge capture processes and reconciliation. Reconciliation through software or some other means results in prevents the loss of earned revenue, which degrades your bottom line. We already have a negative margin. We can't afford to lose charges too. Supply and pharmacy, we've talked about that. And then aggressive management of costs. So this is interesting now. The pandemic is making middle revenue cycle really that hot spot for cost management. Not only are you controlling your charges, you're now going to be having to look at the data for the costs. Aggressive management of patient interaction. We can no longer afford to lose patients. We have to get enhanced touch point through telemedicine, software like Twistle, that does the interactions through their lifespan of care. So if they had a cardiac bypass, then they're going to touch point all the way through to make sure that they have a good outcome, lower the readmission rate, all of that. Management of referrals at discharge, making sure that you refer to somebody within your system that can see the patient. So what I see in most ER things, follow up with past medical doctor. I'm homeless and I don't have one. I made no effort to find a referral within the system for them to follow up with. So we need to start looking at simple things like that. Pop health has become first and foremost now. You see it in many of the software vendors. They have population health management. This has been impacted during the pandemic, and much of the data from Pop Health has helped us manage the pandemic for better outcomes. So we're going to need to re-engage those Pop Health measures and revenues and cost migration so that we get the patient taken care of in the right place at the right time for the right procedure at the right price. So at this point, I think I have like 2 minutes. Marie, what would you like to do with the questions?
We only actually have one question right now that came into the chat panel, and is medical malpractice insurance a large part of healthcare costs?
Oh, absolutely. It always has been. Tort reform has been required. Not only malpractice, we're starting to see people start to talk about surprise billing. Surprise billing is not a concept known in any other country but us. So we keep chasing the charges and the reimbursement. And in order to be successful and start to do tort reform, whatever, we have to flip this thing on its head and start to look at cost management and quality outcome. Culturally, that's a huge shift for America. And with a administration that could change every 4 years, we never seem to stay on one track. It's always back and forth. So yes, tort reform was, I think about 8 years ago, a big thing. But medical malpractice, yes, because if you're in England and you have a headache, there's no chance you're getting a CT scan unless you are a result of a trauma or you have some sort of neurologic change. We're not going to send every kid with a migraine through the CT scanner. In another country that I worked in, if somebody said I have a urinary tract infection and they had the symptoms, I treated the urinary tract infection. I didn't send off a urine. I didn't send off for culture. We didn't do that for 3 or 4 days after it was treated. So in other countries where I've worked personally and others have communicated with me, high dollar testing doesn't happen. And there's no reason for it to happen because the litigiousness is not there. In Australia and New Zealand, if you have a medical malpractice, you admit it to the family and the hospital settles with the family right then and there. There's no litigious situation where there are $25 billion outcomes or things like that. So yes, absolutely. That is a point.
Great.
What else?
That's the only question we have today.
Wow.
Yeah.
I thought there would be way more, but okay.
I guess you were very thorough today. That's a good thing.
All right. Well, if they come up after, you know how to write Marie, and we'll see if we can't post the FAQs and what have you. But remember, this is part 4 of a 5-part series. The next part, Marie, what's the next one in September is?
September 15th. The topic is new trends we're seeing in hospital charge capture, and we'll have that posted on our website fairly soon, within the week, I would say.
Great. So as always, we want to thank you for being a participant in today's. We hope it was informative to you. If you have questions, reach out to us, and wish you all a very pleasant afternoon.
Yep. Thank you so much, everyone.
Bye-bye.